So, Pat Sheets has enjoyed over 30 years of caring for newborns and their families. She received her BSN from the University of Oregon Health Sciences Center, her NNP certification from South Dakota State University, and her Master's of Nursing with an Education Specialty and DNP from Walden University. Her current job entails providing clinical support for the 8,000 plus newborns of Legacy Health in the Portland, Oregon area, including the Telebaby program for remote leadership of neonatal resuscitation. Away from work, Pat enjoys opportunities to teach newborn care to health staff abroad, most recently training NRP instructors and stable program instructors in Vietnam. Please join me in welcoming Pat.
So today we're going to talk about something that I'm sure you've heard about because it's a mandated law in Oregon as well as now 45 states. So we were like, I think 11th or so, and now there is yet to be federal legislation about it, but there's only 5 states left that don't mandate it. So we're going to talk about why that would be, that this would be a mandated, an important public health measure, basically, is what this is. And as midwives, you guys have been for a long time at the forefront of public health measures. For years, you guys have done what they call delayed cord clamping, which we know is actually optimum cord clamping, physiologic cord clamping, which is a huge public health measure, especially around the world, where that blood that is transferred back to the baby or belongs to the baby anyway prevents iron deficiency anemia around the world in lower resource countries, and that's a huge cause of mental retardation around the world. So it's preventing that. It's really huge. The other public health measure is skin to skin. You know, you've been doing that forever. Breastfeeding support, huge, huge public health measure. Have you not been supporting breastfeeding forever? Yes. So you're right in there. Always, you have been leading those efforts. Those are free things that absolutely impact long-term health. So it's huge. We are going to talk today just about a couple things for you guys to know about. Are the implications? Why do we screen for cCHD? Critical congenital heart disease. There's lots of heart disease, and then there is a small percentage that are actually critical, meaning the baby is going to need intervention early on in life to prevent death, long-term disability, or something like that from it. So that's what we're going to talk about. And we're going to try and focus it on in a non-hospital setting. So it really is important to you guys, not some academic blah, 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 blah. So that's what we're going to talk about, and it's one of the things that's important about it is the timing of the screening. So we're going to talk a little bit about that too, and how we can how you can support your patients, even in a setting where they may not be in a hospital, or if they're at your birthing center, not staying for very long in that place. So midwifery is another thing that you guys have been doing that's huge, is that you do home visits, follow up your patients closely. And that, too, is a giant public health and wonderful thing. So I admire you guys greatly. I will. I'll hold this closer. So let's talk about this. We're going to talk about why we do it, because there are numbers of babies who have congenital heart disease. And if Oregon has about 45,000 babies a year, we could see 300 to 400 cases of congenital heart disease. The critical cases are going to be a smaller percentage of that, 75, 100 maybe, of those babies a year. When you talk about screening in public health, we always talk about, is it cost effective, or are we just spinning our wheels or spending money where we shouldn't be, when we know that in these days of the post-factual life that we're living now, that money is everything, and using it wisely is always important. So one case, if we found one case of a baby who needed intervention, that would basically cover the cost of over 2,000 screenings of babies who we're looking for congenital heart disease. And the reason we care about that is because if a baby goes home, and we'll talk about ductal dependent lesions, if a baby goes home and starts to have its heart disease, its neonatal transitional physiology change, from fetal to neonatal, the duct closing, and that duct is supporting the baby's body or lungs, which we'll talk about. That baby comes back to the emergency room in extremis, acidotic, and all sorts of bad conditions that are not the kind of patient you want to operate on. If you're going to take somebody to the operating room, you don't want them to already be acidotic and in bad shape. So by finding these anomalies before the baby suffers from the anomaly, you're operating on a pink, healthy-ish baby, and that really improves the outcomes of the surgeries or the procedures that you need to do for that. So that's the impetus for this whole screening process, is to find those few babies that otherwise would die at home, which they do, or would have a worse outcome even if they had their procedures or their surgeries. So that's really key.